Okay, our first speaker is Tracy Judd, who currently serves as a remote quality improvement advisor for the Center for Quality Health IT Improvement, a program with the UT Health School of Biomedical Informatics. In this role, she focuses on quality improvement, data analysis, and reporting for state and federal incentive programs, as well as electronic health record optimization and grant-funded health IT and quality improvement initiatives. Tracy holds an Associate of Applied Science in Medical Record Technology from the Horton County Junior College and a Bachelor of Science in Health Information Management from UTMB Galveston. Her career spans diverse healthcare settings, including acute care hospitals, access hospitals, nursing homes, and rural health clinics. Throughout her professional journey, Tracy has directed health information management operations, coordinated healthcare accreditation efforts, overseen credentialing services, managed risk to compliance, led performance improvement initiatives, and worked as an inpatient medical coder. Our second speaker, Ella Renee Garza, serves as a research coordinator 3 at UT Health Houston School of Public Health within the Center for Health Promotion and Prevention Research. In this role, she supports federally funded cardiovascular disease prevention initiatives in partnership with the Texas Department of State Health Services. Her work focuses on hypertension control, implementation science, clinic quality improvement, and integrating data-driven and evidence-based strategies to address social determinants of health across federally qualified health centers and community clinics throughout Texas. Ella holds a master's in public health and epidemiology and a certificate in global health. She is a fourth-year doctoral student in epidemiology with a minor in biostatistics and is also an MS candidate in biomedical informatics at the McWilliams School of Biomedical Informatics. Her research interests are grounded in health services research, with a focus on understanding and improving the delivery of care across diverse populations within health systems. Her areas of interest include neuroepidemiology, cardiovascular epidemiology, mental health epidemiology, and health equity. All right, I will go ahead and share my screen and pass it along to our speakers so that they can present on the slides. Just give me one moment. Sorry, I'm having a bit of trouble finding my share screen button now. Okay, is everyone able to see the slides?
Yes.
Okay, great. I'll pass it along to you too.
Well, thank you, Wes, for the warm introduction. Good afternoon, everyone. Tracy and I are grateful you could join us again, and we're looking forward to a great discussion. Next slide, please. So to guide our time today, we'll start with a quick overview of the Prepare background. Then we'll walk through what a step-by-step administration of the tool could look like. We'll discuss how Prepare can be integrated into your existing clinic workflows. We'll also cover patient-centered communication strategies and review important consent and privacy considerations. We'll then talk about resource linkage and referral follow-up. Finally, we'll conclude with a Q&A session to address any questions. Next slide. So what is PREPARE? PREPARE stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. It is a nationally standardized evidence-based screening tool designed to help clinics identify patients' non-medical drivers of health. PREPARE was developed by the National Association of Community Health Centers, or NAC, specifically for community health center settings. The Texas Association of Community Health Centers also encourages its adoption as a consistent and structured way to capture and respond to patients' social needs. The goal of PREPARE is to promote health equity by helping care teams identify social factors like housing, food access, transportation, and financial strain that can significantly impact health outcomes. Next slide, please. So Prepare includes four main domains that help clinics understand the full context of a patient's life and the social factors that may affect their health. This includes personal characteristics, family and home, money and resources, and social and emotional health. Next slide, please. Prepare screening provides important benefits for both patients and care teams. By identifying and addressing non-medical drivers of health, clinics can help improve patient outcomes, reduce hospital readmissions, and lower healthcare costs. Research also shows that unmet social needs can predict outcomes like hypertension and cardiovascular disease. Prepare can also help clinics identify trends and respond with targeted solutions. For example, one community health center identified increased food insecurity through Prepare screening and partnered with their community to create a food pantry to support patients in need. Next slide. Next slide. So to support implementation, Prepare offers an implementation and action toolkit developed in collaboration with NAC. It is organized into three main domains: preparing to gather data, assessing the data, and responding to the data. These phases walk clinics through understanding the prepare process, engaging stakeholders, implementing workflows and EHR templates, and using the data to connect patients with appropriate services. Clinics can assess the full Prepare implementation and action toolkit by contacting NAC directly via email or visiting the Prepare website. This resource provides detailed guidance, tools, and best practices to support successful implementation. Next slide. So phase one is about preparing to gather data on NMDOH, or non-medical drivers of health. At this stage, the focus is on understanding why Prepare matters. The tool helps identify upstream factors like housing stability, income, education, and social support that shape patients' health long before they develop chronic conditions. These upstream factors influence downstream outcomes like health behaviors, disease progression, and overall health outcomes. By preparing to capture this information systematically, clinics can begin addressing root causes rather than only treating symptoms. During phase one, clinics also explore available Prepare resources, including the screening tool itself, EHR templates, translations, a readiness assessment, and the implementation toolkit to ensure they are fully prepared before launching screening. Next slide. Thank you. Successful implementation depends on early buy-in from staff, leadership, and patients. Clinics can introduce Prepare at an all-staff training, or meeting, recruit volunteers, and identify project champions who can help lead and sustain the effort. Training staff and designing ways to meaningfully engage patients in the screening process are also critical. It's equally important to create opportunities for shared learning, develop clear resources for both staff and patients, and maintain motivation over time. When messaging about Prepare, emphasize that screening is not about adding extra work. It's about better understanding patient situations so the care team can provide more comprehensive support and connect them to resources when needing. Engaging stakeholders early builds trust, strengthens workflow integration, and increases the likelihood of long-term success. Next slide, please. So chapter 3 focuses on strategizing the implementation process before launching Prepare. A helpful first step is using the Prepare Readiness Assessment tool to evaluate your organization's readiness across key areas: organizational culture, leadership and management, technology infrastructure, and workflow processes. Clinics are also encouraged to apply the 5 RHIAs framework. More on that later. Next, select a focus population. This could include all patients, new patients, or a specific high-risk group, depending on your clinic's capacity and goals. Finally, you'll want to develop a realistic implementation timeline. As shown in the example, timeliness can vary depending on organizational readiness, but planning in phases helps ensure a smooth and sustainable rollout. Next slide. Phase 2 focuses on assessing the NMDOH data beginning with technological implementation. Prepare provides EHR templates to support structured data collection. The Prepare YouTube channel offers video tutorials that demonstrate how to integrate the tool into EHR systems, including examples of workflows and template usage. Free Prepare templates are available for several major EHR platforms, including Athena, Cerner, Epic, and the others listed here. Prepare also follows a standardized risk tally methodology to help clinics consistently score and interpret data. For those clinics who do not have a designated template, an Excel spreadsheet is available within the toolkit to support data collection and tracking. Next slide, please. Okay. Yeah, I think you went. Oh, next one. Sorry. There you go. So in phase two, chapter 3 focuses on workflow implementation using the 5 rights framework. Tracy will provide more information on this later, so we can move on to the next one, Wes. Thank you. So chapter 6 focuses on developing a clear data strategy once prepare screening is underway. First, you'll want to outline your prepare data goals, identify what you want to measure, who the target audience is, what your baseline looks like, and how this aligns with your organization's overall vision. Next, assess your data capacity and infrastructure. This includes evaluating your people, right? So, such as your IT team, your leadership, and staff, your current data collection processes, and your technology for reporting and analysis. Then you'll develop and implement a prepare data roadmap. This means determining how data will be organized, accessed, shared, validated, and analyzed. After that, conduct formal prepare data analysis using the recommended 6-step framework. Then, based on your findings, you'll identify and prioritize actions. This may include building community partnerships, planning sustainable interventions, or combining multiple strategies. Finally, act on the data, evaluate outcomes, and refine your approach as needed. Next slide. Chapter 7 focuses on understanding and evaluating your prepare data. There are several tools that support this process, including data validation methods, multi-stakeholder organizational interviews, and staff process evaluation surveys. These tools help ensure the data being collected is accurate, meaningful, and aligned with workflow expectations. The sample process shown here illustrates how data flows through the system. Care coordinators complete the prepare assessment with patients and provide resources when needed. The data is then uploaded into the EHR, where it may also integrate with other clinic systems. Reports are generated regularly to check for accuracy and completeness. Referral reports are compared with prepare assessments to confirm that identified needs are being addressed. Clinic supervisors may conduct observations to ensure assessments are being completed as intended, and they use prepare reports to provide feedback, share best practices, and identify opportunities for improvement. Next slide, please. In phase 3, we focus on responding to the data and building capacity to address identified needs. There are several ways clinics can strengthen their response depending on available resources. First, clinics can create services in-house by developing staffing models, internal processes, and technology to track non-clinical resources and referrals. Second, clinics can form coalitions with community partners and advocate for environmental or policy change. This may include building partnerships, creating resource guides, and using technology to track referrals and measure impact. Another strategy is raising awareness among staff, patients, and partners. This involves training staff on how to discuss NMDOH, reinforcing the value of addressing these needs, and consistently documenting efforts in the EHR. Finally, partnering with community-based organizations and local leaders can expand available resources. This may include supporting local programs, creating electronic referral guides, or establishing volunteer opportunities. Next slide, please. Chapter 9 focuses on acting on your Prepare data. If food insecurity is identified, responses can occur at multiple levels. Clinically, providers can discuss nutrition, prescribe produce vouchers, and connect families to meal programs. At the organizational level, clinics might create food pantries or partner with local food programs. At the community level, efforts can include supporting gardens, working with schools, or collaborating with meal delivery services. The same layered approach applies to stress. Clinically, providers can identify stressors and offer healthy coping strategies. Organizationally, clinics can connect patients to social groups and educational resources. At the community level, initiatives might include strengthening social support systems or promoting low-cost wellness programs. The bottom line here is that Prepare data should lead to coordinated action to address root causes and improve long-term health outcomes. Next slide. Finally, Chapter 10 focuses on tracking enabling services. Tracking these services help clinics understand the value of their interventions and measure their impact on patient health, treatment costs, satisfaction, and access to care. Prepare identifies 9 enabling service categories, including case management, referrals, financial counseling, health education, supportive counseling, interpretation, outreach, and transportation. By documenting and tracking these services, clinics can demonstrate impact, identify gaps, and continuously improve how they support patients' non-medical needs. Thanks for your attention. I'll now turn it over to Tracy.
Thank you, Ella. That was very insightful. A lot of good information there. So now we're going to talk about the integration into the clinic workflows. Next slide, please. The 5 rights framework helps clinics integrate Prepare smoothly into everyday workflows. The idea is to make sure that the screening fits naturally into how care is already delivered. The framework prompts teams to think through these 5 key questions. What the socioeconomic data that is collected so we can gather the right information without over collecting information. How will we collect the data? Through forms, interviews, or electronic tools while keeping patients comfortable and ensuring accuracy? Who is responsible for each step? Collecting, reviewing, and following up so nothing falls through the cracks. Where in the workflow will this happen? Front desk, the exam room, telehealth, or the patient portal? And how will the team access the information? When identifies when is the best time to screen? Will it be at new visits, annual exams, or transitions of care? So that it supports the clinical flow rather than disrupting it. Together, these 5 questions will help the clinics use Prepare efficiently and consistently. Next slide, please. An important best practice to use is value-added time. For example, having patients complete the Prepare screening in the waiting room or exam room while they're already waiting for their medical evaluation. This prevents adding extra time to the visits. Clinics also need to make a few key decisions. On format, will the screening be done virtually, on paper, or verbally? For staff, which team members will be trained to administer the Prepare tool? What information or data is already being collected so we avoid duplication? Timing. Should screening happen before, during, or after the appointment? And then location. Where can patients complete it privately so they feel comfortable sharing sensitive information? These decisions enable clinics to integrate Prepare seamlessly into daily workflows while enhancing patient comfort and operational efficiency. Next slide, please. The most common challenges clinics face when implementing Prepare can be solved with practical solutions. First challenge may be clinics may not clearly define who is responsible for the screening, when it happens, or where it's going to take place. The solution to that challenge could be to create a clear workflow by assigning specific staff, choosing the screening format, deciding on the location, and determining the timing. A second challenge may be that patients feel the questions are way too personal or not relevant to their medical care. A solution to this is to provide privacy, create a comfortable setting, and clearly explain why the questions matter and how the information will support their care. The third challenge that clinics struggle with is they may not follow up after identifying the social needs. The solution to this is using a tracking system such as the EHR or a referral database such as Unitas to document referrals and ensure patients receive follow-up support. Overall, the goal is to remove the barriers by improving workflow clarity, providing patient comfort, and following up on processes. We will cover all of these areas next. Next slide, please. This workflow shows how prepare can be completed before the visit by non-clinical staff. The advantages to completing the prepare before the visit is that the provider has the results during the appointment, which will help him or her guide the treatment. It doesn't add any extra time to the visit. However, some trade-offs to this situation could be if the patients arrive late or the waiting area is busy, which could make the screening process a bit harder. This is how the process could work. Administer while the patient waits. Non-clinical staff explain the purpose of prepare and the patient completes it, either independently or with assistance using paper or a tablet. Document the responses. Staff enters the answers into the EHR and use appropriate Z codes when available. Provider visit. The provider reviews the prepare information and incorporates the patient's social needs into the care plan. Respond to the needs. If needs are identified, staff or the provider will connect the patient to the appropriate resources. And then finally, closing the loop. Staff then follow up to confirm whether the patient accessed the resources and documents those outcomes into the EHR. Next slide, please. This workflow describes for you how non-clinical staff administer the prepare social needs screening after the provider visit. The advantages to this workflow is the provider is not delayed during the visit, and the immediate handoff to referral services can immediately occur. Some of the trade-offs is that providers do not have prepare information during the visit, and the process may lengthen the overall visit. Some of the workflow steps to consider is the clinical visit with the provider. The provider is the one who completes the visit and directs the patient to the non-clinical staff for prepare screening, either routinely or as needed. This can be done as a referral to non-clinical staff when the staff explain the purpose of the prepare and how it supports the patient's care plan. They can also administer prepare and guide the patient through the prepare questions, either self-administered or assisted, and record those answers into their electronic health record. Responding to the needs. The provider or the staff connect the patient to the needed resources, either those in-house or community resources, and any unmet needs will trigger a flag for follow-up screening at the next appointment. And again, closing the referral loop. Non-clinical staff follow up with the patient to see if the referrals were used and document that information into the electronic health record. Next slide, please. Now we're going to talk about patient-centered communication. Patient-centered communication means communicating with patients in a respectful, culturally humble, and understanding way. Prepare includes sensitive, personal questions, so conversations must be handled with care and the patient's appropriate language. Staff should build trust and show empathy, especially when discussing difficult life circumstances that are affecting the patient's health. Next slide, please. Excuse me. Outlined here are 4 key principles of health equity-focused patient-centered communication. It's good to avoid adjectives like vulnerable or high risk because they can stereotype. We encourage you to use person-centered language, such as describing the people as having a condition, not being the condition. Subpopulations, we want you to be specific about the group that you're referring to, but we want you to avoid broad or unclear categories. Be mindful of tone and context to avoid stereotypes or unintentionally blaming patients for their circumstances. Next slide, please. Supporting patients through health literacy and language access include providing prepare in many languages, using bilingual staff or translators, asking patients what language they prefer if personal language is unclear, and then helping patients understand their health by giving clear explanations, translated brochures, and connecting them with health literacy classes. Next slide, please. Using equitable, patient-centered communication will build trust, support better self-care, and increase the chances that patients will use the referral resources, which will then lead to improved treatment adherence and better health outcomes. Here are a few examples of how to replace language, such as poor people to with persons living below the poverty line, or minority population to naming the specific population. When unsure of the patient's native language, always ask the patient. Next slide, please. Let's now learn about consent and privacy consideration. These next few slides contain a lot of information, and I'm going to try to highlight for you just the key points while still making sure that we don't lose any essential meaning and content. On this slide here, we can see that while most patients respond positively to prepare, we've heard the questions that they feel the screening is too personal, it's not medically relevant, or it's intrusive. And it's important to explain the purpose of the questions and respect the patient's privacy concerns. Maintaining privacy and consent relies on 3 key principles: protecting patient trust and safety, upholding ethical standards, and following legal requirements. Next slide, please. These 3 key principles that were mentioned in slide 32 are better explained here. Protecting patient trust and safety is completed by informed consent. We want to tell the patient what data is being collected, who can see it, and why it's needed, and where it will be stored. We want to build trust by explaining this clearly before collecting any information. We never want to share patient information unless the patient gives permission. And finally, communication. We want to use open, empathetic conversations to help patients feel comfortable and ensure that they understand why the information matters to their health. Next slide, please. Patient privacy is further protected both ethically and legally with autonomy. And that's patients having their right to decide what information they want to share. Beneficence, we want to make sure that patients understand the benefits of Prepare so they can make informed decisions by choice. In justice, we want to ensure all patients, especially the vulnerable groups, are supported fairly by the Prepare screening tool. And beyond this, we also need to follow the federal privacy laws known as HIPAA, which protects all patient health information. The privacy rule tells us how we can use and share patient health information, and the security rule requires us to keep electronic information safe. Next slide, please. Resource linkage. Perhaps Prepare helps connect patients to the right resources and integrating it into the electronic health record to make the process even more stronger. Once Prepare identifies a patient's need, we link them to support through three main pathways. Either they're the electronic health record, referrals to clinical or non-clinical services, and community resources. Research shows that when Prepare is built into the electronic health record, clinics can collect, track, and follow up on social needs more effectively. Studies have found increases in routine visits, vaccinations, and regular ongoing care. These improvements happen because electronic health records help us follow up consistently and close the gaps to support the patient. Next slide, please. Prepare helps links patients to both clinical and community resources. Clinically, patients may be connected with mental health providers, social workers, case managers, insurance support, or translation services. Community partnerships are also important, such as food banks, mental health support groups, and insurance education programs. Keeping an updated list of these resources will help the providers quickly match the patients with the support that they need. Next slide, please. Referral follow-up. Following up on social needs referrals is essential for improving the patient's health. Closing the loop means checking whether patients used resources they were referred to and if those resources met their needs. Clinics that do this consistently see better outcomes. Effective follow-up includes tracking the referral, contacting the patient, evaluating whether the resource helped, and adjusting future referrals based on patient feedback. Next slide, please. If you would like to learn more about Prepare, this slide identifies for you the Prepare website, where you could find additional information to any of your questions. Next slide. Identified here, go back to the references, our list of references that we use for this presentation. Next slide, please. And finally, in closing, UT Health Houston School of Public Health, specifically the Coalition for Connected Care and the McWilliams School of Biomedical Informatics, Center for Quality and Health IT Improvement, thank you for attending this presentation today. As you've heard, implementing Prepare effectively requires thoughtful planning, clear workflows, and consistent follow-up. When clinics define who is responsible, when and where the screening happens, how the information is collected, the process becomes smoother for both staff and patients. Addressing patient concerns through privacy, clear communication, and supportive environments help build trust and encourage honest responses. Finally, using structured systems especially electronic health record-based tracking, ensures that referrals are followed through and patients receive the resources they need. By strengthening each part of this screening process, clinics can close referral gaps, improve patient outcomes, and ensure social needs are fully integrated into quality care practices. So that concludes our presentation. Heidi, can you open it up for our question and answer session?
Yes, I can. We've got some busy chat here as well. Um, so kind of summarizing because there's a fair amount there. I know a lot of the work that you all have done is you've been working with some of the local clinics and healthcare entities. Can you talk a little bit about some of the linkage of these recommendations to what you were maybe themes that came out across the different clinical operations in our region? And the framing there is the question in the chat is around the evidence behind the role specifically of technology in improving outcomes. And we can dive into that a little bit more, but just kind of as a framing startup.
Ella, do you want to take a stab at that? It seems pretty complex to me.
Sure. So I was following the chat. Thank you, Greg, and others for the discussion. That's what these sessions are meant for, right? So I think it's a really important point that you've brought up, and I agree that the evidence base is nuanced. The literature doesn't show that screening alone automatically improves clinical outcomes. That's absolutely correct. But there are studies that suggest that screening without clear workflows or referral pathways or the resources necessary can create a burden for providers and patients. And we would think that's why NAC has put this toolkit together that addresses all of these different areas, right? So where we tend to see stronger evidence is in a more comprehensive model. So when screening is embedded with a system that includes the closed loop referral, right? And community partnerships and follow up to support, that's when we see better outcomes. And it's pairing these screenings with navigation and or case management and so on. So I think the key distinction is not screening versus not screening. It's more how screening is implemented and whether it's meaningfully connected to action, right? So we've seen that in our clinics. One of the examples that NAC provides is the food pantry. But in our grant work, Tracy and I have helped the clinics implement the screening process, and they've discovered to their surprise needs they didn't know or they were surprised existed within their patient population. We've had clinics do internal food pantries, right, and connected clinics all over Texas with housing services, transportation, things that they didn't know their patients were struggling with. So it is very telling, and so far, I mean, based on those testimonies and the number of screenings and positive findings and referrals made, I would say our clinics are, the patients are benefiting from the work that's being done. I don't know, Tracy, if you'd like to add something else. If you had a chance to read the chat, there were several back and forth responses. But if you do want specific citations, Greg, I believe, and these aren't ours, right? We're presenting NAC's information, right, on Prepare. But I believe in our first presentation, the recording should include a list of references that NAC provided and also others that we added on. So if you want to look there, I think that's a good place to start.
Good job, Ella. I don't have anything to add to that.
I mean, Heidi, maybe you want to add something. You all are doing all this great work and closed loop referrals. Maybe
Yeah.
there's something else you can add.
Yeah, I thank you, Greg. I always appreciate your thoughtful questions. Um because I don't know. So I'm reflecting back on all the different, publications. I don't know that I've seen studies designed specifically to look at the referral process with technology versus without technology. I know that the work that Siren put out and some of their results, I think that came late 2024, early 2025, they were definitely finding improvements in the screening and referral, and consistent with what Tracy shared. The screening and referral was improving outcomes even if they didn't get the service. So the thought was that patients were feeling like their providers cared for them. There was a whole write-up on that in a presentation I attended that, oh gosh, I'm blanking on her name, but one of the head folks at the SDOH part of Siren. So you have your hand up. Did you want to chime in directly?
Thanks. I appreciate it. And this is a tricky, nuanced topic, but I just want to tease some stuff out. We know that screening can have negative effects if it's not implemented properly, if there's not capacity to follow up. We know that delivering, that connecting people in need with food can be effective. But it's not clear that screening and referral technology and all the data collection associated with it is actually a necessary condition for connecting people to food. And I haven't seen evidence that collecting lots of data about people and their social situations and then trying to refer them to services actually has improved outcomes. And it does seem like the evidence is showing that building workforce capacity to engage with people can be effective.
Yeah.
And paying for service delivery can be effective. It's not clear that setting all of this process of gathering data, surveilling people, and then following up with, integrating workflows. I have yet to find any evidence that that is effective, but from community by community, I don't know, I only work a little bit in Texas, but community by community, that's what health systems and community organizations are being pressured to do, is implement these data gathering systems and all kinds of complex technology workflows, even though it doesn't seem like there's an evidence base that supports it.
I think it's really important for us to think about as we're building out some of this work, especially as data collection and folks are justifiably concerned about how data is being used, and how surveillance systems are being set up. So I think it's an important thing for us to be thinking about as we're building these out. I appreciate it, Greg.
Sure, and I appreciate the discussion. I'll just explain the Siren study that I referenced, or from University of Chicago, and there was a conversation in Siren. They compared screening processes with alternative processes where they asked people, do you need help of some kind? And if they said yes, they provided them information about available resources, and that was it. And the latter consistently overperforms compared to the screening and referral processes.
Interesting. If you have that link handy, we'd love to share it out with the recording.
I've shared one study, and I'll share the discussion about it.
Great. Thank you. Appreciate it, Greg. For those of you who don't know Greg, he's a part of a lot of the national conversations of building out the standards around this type of work.
I'm in these conversations, but I'm the only person turning around and saying, we've been doing this for years and we don't have success. And the idea of informed consent is a principle, but it is not achievable in practice. So like the downsides of this work are really significant. Collecting more data about vulnerable people is like intending to do it with their informed consent does not actually make it safe. And getting somebody to say, yeah, I read this and I'm hungry, I need food, my doctor is asking me to sign this thing, I'll sign this thing. that does not mean that they have truly understood and consented to what they're doing, and it does not mean that what is being done is safe. Having the intention that the data should not be reused in other contexts, blah, blah, having that intention does not mean that you are protecting the data. So I think there's like really important questions to be asked about the downsides for which we don't have good answers. And it's not actually clear after all of this time that all of this implementation of technology and collection of more data is necessary to achieve the objectives of getting food to people or directing them to resources. I'm not trying to say we should not try to get food to people. Certainly not trying to say that. It's just like, why do we think that there has to be this elaborate mousetrap in order to do it, as opposed to just be like, do you need food? Here's food.
And how do we put patients, I know this is another like related to that, the patients in the driver's seat of knowing where the resources are and what are the steps and following through.
Sorry
Thank
to
you for that.
barge in. Thank you
No,
for hearing me out.
I appreciate your contributions. Other comments or questions? Because I know this is really complex work. It's work that goes beyond the role of any individual organization. That's part of the reason why this coalition really, like members, we called for these types of conversations. We called for this type of work of how do we figure it out? And how do we figure it out in a way that's guided by those we serve? Perhaps any thoughts of what you've seen in your spaces? I know many of you are working in different clinical spaces, of questions that have come up from the patients. Or maybe Tracy and Ella, of the work that you're doing, do you have any comparisons of different methods? I know each clinical site really has their own workflow of how they're doing screening and referring, and what the role of technology may or may not be in that process. Particularly as in some places, Prepare is built into the EHRs, and in others it's not.
One thing I'd like to share that our clinics have been really surprised by is the complexity of the patient needs. Once they start the screening process, they find that they become overwhelmed and inundated with trying to get the patient those resources, and they don't have enough staff to be able to manage what their screenings are identifying. And, that's something that quickly escalates, and it's really hard for them to get a handle on it and be able to get those resources back to the patient. Another thing that we've heard is that, sometimes those referrals to places like the food bank cannot compensate for the influx or the volume of what's coming to them. So that in itself can create a little bit of a barrier to the patient receiving the help that they need, if they can't get the resources from the organization. So it's just, like I said, eye-opening the whole way around, and, just trying to be as conservative as possible when you set up your screening process. There is no regulation on it being done every visit. Some of our clinics, because of how overwhelmed they've gotten really quick, have went to saying we do it every 6 months. We're only going to do it once a year. And those are things that they need to consider, with the complexity of the chronic conditions of their patients, because, just administering a screening once a year, may not give them the resolution that they like to see from the resources, but then doing it every 6 months or at every visit, creates just a very overwhelmed situation way too frequently. So, those are just some things that I'd like to share that we've learned.
Appreciate that, Tracy. G, do you want to chime in?
I had guess a question, maybe looking for recommendations based off of a current assessment that we're doing of our screenings that we do at Harris Health. So we're assessing our current strategy system-wide, and some feedback that has come up from our care managers, kind of relaying what some of the feedback from our patients have been, is that sometimes the questions are hard to understand. And I think it's important to know, right, that we are a safety net system. And so we do have very vulnerable populations. And although we use standardized screening methods, not all of it is prepare based. But we do use standardized screening methods. And so we're just kind of, I think, running into that dilemma of what do we do with the screening questions, given that they are validated, but our patients are still reporting, having some struggles understanding the questions or what's being asked of them. So I guess I'm just looking to see if you all have received similar feedback or have any experiences with teams that are dealing with similar issues.
Tracy, do you want to answer?
Sure. So usually what we see when there's that need is the social services department or a community health worker are the ones that are working with the patient, so that way the context of the question is better understood. We've also seen some organizations only implement a small subset of the 26 questionnaire. They maybe just go in and only ask 4 questions now, do a slow and a gradual implementation. So that way, they're not inundating the patient too quickly, with the information. And then of course, just having somebody there to work with the patient. So that way, if the context is misunderstood, there's somebody there to explain it to them. We've also heard that some of the patients prefer to have the material presented to them at a 3rd grade education level. And when you look at the Prepare screening tool, it's not presented in such a way. So, the organizations are having to simplify, what's being asked there to, meet the population's need of understanding the question.
I think the only thing I would add, and it's clear, I mean, from what you're saying, is this has been an iterative process for all of our clinics. So when we've helped them develop workflows, sometimes it's, we've gone from the CHW doing the screening to just kidding, we're going to have the social service team do the screening, so it's all about finding the right fit. And the other thing is we do encourage our clinics to use collaborative communication strategies. So, that has seemed to help so far from the feedback that we've received.
All right. Well, that I know that we're almost at the end of the hour. What we can do is I will save the chat so that all these, especially these studies referred to, we can send out to the group. I know that a few are interested in looking at this toolkit. NAC does require you to directly reach out for it, right? That's correct, right, Ella? So we'll put that link. You just need to we'll put the link where you reach out if you're interested in obtaining it. We'll put the recording up and send it out to the group. And we'll also put the link to the past session if you were interested in looking at it again or seeing it for the first time. And again, thank you everyone for your participation, and thank you again, Tracy and Ella, for presenting. And hope you guys have a good weekend. Enjoy today.
Thank you.
Bye, everyone.
Thank you all. Appreciate it.